I am Dr. Sapkal here. The title for discussion today is Ripening of the Cervix and Remodeling of the Cervix. These are the changes which occur in the cervix with the term, at term. Here I have given one case scenario so that you will understand the facts about the ripening of the cervix and what is the plan of the treatment in a patient with a unripe cervix and a ripe cervix. Okay. So, here the woman of 31 years of age, she is a primi gravida and BMI 30, reported at 37 weeks of gestation. On admission her blood pressure was 150/90 and there was no proteinuria. LDH level were 300 IU per ml. There were no signs symptoms of pre-eclampsia or imminent eclampsia. Platelet counts were normal. For abdomen examination, it was 37 weeks pregnancy with 36 weeks or term pregnancy with vertex left occipital anterior position, head was fixed, Leica was adequate, there was no fetal compromise and fetal heart was 140 per minute and regular in rate. Digital examination or internal examination or pelvic examination showed the cervix was 50% effaced, 1 centimeter dilated, head station was -1 station, cervix was firm in consistency, anteriorly placed and membranes were there. With pelvic assessment as normal or adequate. Describe the obstetric plan of treatment for this patient. This is the case scenario we will discuss today. Okay. So, what is the conclusion and what is the diagnosis, what will be the plan of treatment, let us discuss in relation with this title. In this case, the digital examination findings demonstrate Bishop score. Bishop score decides likelihood of the imminent delivery, whether vaginal delivery is possible or not, that is determined by the Bishop score. These are the biological changes which occur in the cervix. They are described under the heading of ripening of the cervix. They occur 2 weeks before the onset of true labor pains. Thus, by assessing the cervix, we can make out what is the status of the patient, whether she is near term or she is preterm, like that. Ripening is mainly due to changes in the composition of the extracellular matrix of the cervix. Bishop score as such deals with the 5 points. It is a clinical ST examination. It predicts the chance of vaginal delivery. What I mean to say is, this unripe cervix requires intrauterine pressure of 10,000 millimeters of mercury and the ripe cervix requires only 1600 millimeter of pressure, intrauterine pressure for labor to occur. This was the scoring, Bishop scoring, which was given by Edward Bishops in year 1960. This year you remember 1960, because next 1984 the other modification was there. So, the original Edward Bishop score was given in 1960. There are 5 changes total. Cervix becomes soft in consistency. There is effacement of the cervix and internal loss. Effacement is due to the descent of the presenting part and the fetal head. External loss becomes spatulous and opens to some extent 1 to 2 centimeter. Cervix is posed, mid-posed in the direction of the birth passage. Vagina and introitus is anteriorly placed. So, the anteriorly placed cervix is the best cervix to dilate. Architecture of the cervix changes with 2 weeks prior to the expected date of delivery. In these cases, the cervix becomes soft in consistency, it is anterior-placed directed, means it is in the direction of the introitus. Dilatable and stretchable to some extent because of the activation of the myometrium. We have learned in the last class how this activation takes place, and there is also effacement of the cervix. What do we understand by the effacement of the cervix? There is opening of the internal os and it results into formation of this lower uterine segment, and it also forms due to the descent of the presenting part at term in nullipara. It is effective due to relaxin hormone also, due to descent of pressure of the descent of the head also, as a result of brachionic contraction also. So many factors are contributing for this effacement of the cervix. First one is estrogen formation by the placenta, which releases prostaglandin E2, and there is functional withdrawal of the progesterone hormone. So, initially in pregnancy, the uterus is in the quiescent phase, where this with the onset activation phase, there is withdrawal of this progesterone hormone, and estrogen progesterone ratio, it increases. With this, there is release of contraction associated proteins. These are the receptors for this oxytocin, prostaglandin. So, for uterotonics, these are the proteins which are the receptors over the surface of the uterus. There are uterine contractions, but they are of low frequency and low intensity. That is how initial dilatation of cervix is hardly 1 to 2 centimeter, and there is also effacement of the cervix initially, that is 30% effaced cervix is there. So, this is what is the beginning of the ripening of the cervix. Why these changes occur in the cervix at term? Local release of prostaglandin E2 is there by the amniotic membrane, which causes increase in the water content. There is increase in the hyaluronic acid with the use of dermatin sulfate, and with this increase of hyaluronic content of the cervical matrix, the widening of the intercellular distance of collagen fibers, and this hyaluronic acid reduces the collagen and the protein concentration in the cervix with the collagenase enzyme, activation of this collagenase. This collagenase also cause a release of interleukin 188L, interleukin, release of metalloproteinase 2 and 9, and there are changes in the MMP. It means matrix metalloproteases, these are the enzymes, and release of GAGs, I mean glycosaminoglycans, these GAGs. So, there is due to these changes occur due to activation of this collagenase. With this, collagen fibers in the cervical stroma, they break down, and there is a rearrangement of these collagen bundles across the cervix, and that is how the cervix becomes soft and becomes stretchable. During pregnancy, the cervix is uneffaced, and with the activation phase, there is a ripening of the cervix. What do you understand by effacement and what do you understand by dilatation? Let us try to understand. What do you understand by effacement? It is the opening of the internal os, and it occurs due to Braxton Hicks contraction and the descent to the head, we have discussed. Dilatation of cervix, where it occurs at the external os. So, initially there will be effacement of the cervix, followed by there will be dilatation of the external os, which is made out by digital examination. If this photograph is of effacement, this is uneffaced cervix and their effacement has started. So, it is the internal os which has opened. So, here there is opening of the internal os. This is known as effacement of the cervix. Here the cervix is already effaced. Next, there is dilatation of the external os due to the descent of the head. The head is descending down, and subsequently it causes dilatation of the external os. So, this is hardly 2 or 3 centimeter dilated cervix, and it is more than that, dilatation of the cervix. So, dilatation of cervix occurs at the external os, effacement occurs at the internal os. Initially there will be effacement of the cervix followed by dilatation of the external os. This effacement of the cervix is progressive and it enhances with the onset of true labor pains. But whenever there is ripening of the cervix, initially the cervix is uneffaced before the activation phase. It is uneffaced, it is long normal length of the cervix is there. External os is closed, internal os is also closed. This is described as uneffaced cervix, means internal os is closed. Next, there is 25 to 30% dilatation of the cervix. This is how the cervix gets stretched at the internal os. Followed by next step, next scoring is 50%, means this much 50% length of the cervix is felt on PV, 50% is taken over for the stretched over to form the lower uterine segment. Okay. Next, it will be progressive dilatation, stretching of this internal os with it becomes horizontal, so little horizontal in direction, and this is how the bag of membrane and the descent of the head helps for the further effacement of the cervix up to 70%. Step 4, here fully effaced cervix means it is vertical and fully opened internal os. Internal os is not there at all. It is associated with the dilatation of cervix. So, it is 100% effaced cervix. This dilatation is effective only with the true labor pains, onset of true labor pains. To some extent, there is dilatation of cervix, say about maximum 3 centimeter or 2 to 3 centimeter with the ripening of the cervix. Lower uterine segment develops from the isthmus of the cervix due to effacement and engagement. So, this is how the lower uterine segment forms. So, what is lower uterine segment? It is the part between the anatomical, this is the anatomical internal os and histological internal os. So, from this portion there is formation of lower uterine segment, this one stretches. Then it stretches with the advancement of the pregnancy till term. So, how much stretching is there? Hardly 3 inches. 3 inches is the ideal length of the lower uterine segment. With the onset of labor pains, there will be further stretching of the lower uterine segment. If there is prolonged labor, it may turn into overstretched lower uterine segment and formation of the retraction ring. So, this what is lower uterine segment you must know. This lower uterine segment we open up while doing cesarean section. So, with true labor there is further stretching of this lower uterine segment. So, if there is formation of the lower uterine segment, that means the effacement of the cervix is already there. In these cases, we have described how the dilatation and effacement progresses. Not effaced and not dilated. So, cervix will be long, say approximately 3 centimeter in length, 3 to 4 centimeter in length, and internal os is closed. So, not effaced, not dilated cervix. Here the cervix is fully effaced and 1 centimeter dilated. So, it is horizontal in direction and very small portion is felt, 1/4 portion or small portion is length of the cervix can be identified. 1 centimeter dilated means 1 finger loose cervix may be there. This is 5 centimeter dilated fully effaced cervix. This is fully dilated cervix with the formation of this lower uterine segment which gets stretched, and here is the cephalic presentation with the head down. In these cases, while doing lower segment cesarean section, we give incision over the lower part of the uterus. Here transverse incision is given after opening the abdomen, and we deliver the fetus through this route during lower segment cesarean section. So, this is how lower uterine segment is very much helpful. It is that part of the uterus which is covered with the uterovesical fold of peritoneum. So, this whole portion is covered by the uterovesical fold of peritoneum, which is first opened and then myometrial fibers of this lower uterine segment are opened while doing the lower segment cesarean section. Effacement and dilatation of cervix occurs with the onset of labor pains in multipara. In primigravida or nullipara, the effacement occurs and dilatation also to some extent, say about 1 or 2 centimeter occurs 15 days before expected date of delivery due to engagement of the head. Head enters into the pelvic cavity 15 days prior in primary. However, in multi, when it enters with the onset of labor pains. Naturally, effacement and dilatation occurs in multipara with the onset of labor pains. What do you understand? What is the difference between these two conditions, multipara and primary? In multipara, there is formation of lower bag of membranes, and this bag of membranes and like a low down gets entrapped between the lower uterine segment and the head. That is how there is conical bag of membranes here with the effacement of the cervix. This favors dilatation of the cervix with the Ferguson's reflex, means pressure of the head over the cervical margins cause the stimulation of these Ferguson's sympathetic complexes over the cervix, and there is increase of uterine contraction, that is known as Ferguson's reflex. So, this is lower bag of membranes. So, on pervaginal examination in multipara or primary, whenever there is bag of membrane, it is understood any time whenever there is beaking bag of membranes, it is understood it is a patient is in labor. In cases of abnormal labor or prolonged labor or ill fitting presenting part, the bag of membrane will be elongated. In cases of vertex presentation, well fitting presenting part, the bag of membrane will be saucer shaped. So, this is the shape of the bag of membranes in normal vertex presentation with well fitting presenting part, and this is the elongated bag of membranes in cases of abnormal position like occipito-posterior position. Next, we interpret the station of the head also. What is station of the head? How do you describe? Ischial spine is the 0 station. 1 centimeter above ischial spine is -1, 2 centimeter -2 and 3 centimeter -3. Whenever the head is at -3 or -2 station, it is always fixed. When the head is at -1 or 0 station, it is engaged, and when head is at +1, +2 means below 0 station, those many centimeters, it is near the perineum. So, at +2 and lower down +3 station, the instrumental delivery is conducted. So, this station of the head in Bishop's score is predicted, starts from -3, then -2, then -1 and 0, +1 like that. So, the station of head is also predicted in the Bishop's score. Position of the cervix. What do you understand by this position of the cervix? Here, this is the direction of the uterus, cervix in the vagina. So, it is like this, directed like this. Introitus is anteriorly, and the normal cervix, favorable cervix, the direction should be anteriorly placed cervix. So, here in these cases, this is how the direction of the cervix will be in the direction of the introitus and vagina and next introitus. So, position is described in 3 ways. When it is favorable, I will say it is anteriorly placed, means nearer the pointing nearer the pubic symphysis. Mid post cervix, this is mid post cervix, this is posteriorly placed cervix, or even we say it is a sacral os. So, it is a worst position. So, this is better than that, and the best is anteriorly placed cervix. It is this position is better for dilatation. This anterior placed cervix is better position for dilatation in labor. So, in short, what the Bishop scoring describes? It describes the position of the cervix, consistency of cervix, effacement. So, this measurement have score ranging from 0 to 2 in total, and dilatation and station of the fetal head, highest score will be 13. So, these are the 5 points which are assessed in the Bishop scoring system. So, original Bishop score estimates these points: dilatation, effacement, station, consistency and position. This last column for that is blank. So, the scoring is 0, starts from 0, remember, then 1, 2, 3 like that. The scoring is in relation with the dilatation of cervix. So, how to remember this? First, you remember this middle part 1. It includes dilatation starts from 1 to 2 centimeter, the effacement is 50%, and this is also -2 station, it is just fixed, and this is M, means medium cervix and mid post cervix. This is medium consistency. and this is mid place cervix, position of the cervix is in the midpoint. So, this central one column you remember column number 1. Then you come one column here and go ahead one column here. So, what is here 0, less than that 0%, this is beginning is 30% and beginning is -3 station. This is firm in consistency means bad and posterior place cervix is bad. So, here now you can estimate this point. So, whenever cervix is uneffaced, undilated, uneffaced, long 3 centimeter, head at -3 station, firm in consistency and posterior place cervix is a poor cervix or unripe cervix. This is progressive dilatation. So, this we have discussed. Now, next is this also 3 centimeter 60% effaced, head nearer the 0 station, -1 or 0 is good, and soft consistency anteriorly placed cervix is the good cervix. So, this scoring is the best. In this column if scoring comes in the column number this with the score 2, then it is a ripe cervix, and this is better than that, it is with the scorings of 3. Already half of the cervix is dilated, more than 80% effacement is there, head has descended down below the 0 station. This finding is usually onset of labor pains. So, you remember this column first, calculate this one, or remember these points for unfavorable cervix and these points here for favorable cervix. This is how in short you remember the scoring, so that it is easy for you to judge whether it is a ripe cervix or unripe cervix. So, total scoring will be 13. Score of 8 to 13 is favorable cervix, score of 0 to 5 or even 7 even if it is unfavorable cervix. There is modifiers. There are some modifiers in this scoring system. These points also you have to remember while calculating the score. So, what happens here? 1 point in the total score is added if patient had 1 vaginal delivery. If 1 vaginal delivery, then 1 point is added. If 2 vaginal delivery past history, then 2 points are added. Like that the scoring will improve with the number of vaginal deliveries. This is one thing. Then if past history or patient already has got pre-eclampsia, then +1 should be added in the score. 1 point has to be subtracted from the total score in case she is nullipara, she is not experienced of vaginal delivery. Naturally her cervix has not already stretched, it is a nullipara. So, bad to dilate, so 1 point is subtracted. Post date and post term pregnancy, here also dilatation is not good, so 1 point is subtracted. Preterm premature rupture of membranes, this is preterm rupture of membranes. That is why I told you the membranes they favor for dilatation of the cervix. If already membranes are lost, then -1 point has to be subtracted from the total score. This is how in the total score either we add 1 point or we subtract 1 according to the criteria we decide. So, what is this modified Bishop score? To calculate the consistency and position of the cervix is little difficult, that is why, and it is not that important in Bishop score, that is why we have decided that we will minus. Yeah, so, the consistency and position of the cervix are omitted in the scoring. So, what alteration has been done? For dilatation of cervix, double points are given. Instead of 0, 1, 2, 3, we are given here 0, 2, 4 and 6. So, that is how the scoring will increase with this, and cervical length is added instead of effacement. Sometimes we do not understand what is the little confusion in between the two interpreters there, what is the effacement, 50% effaced, 60% effaced, more than 60%, like that little confusion may be there. So, directly we measure the digitally we measure the length of the cervix 3 centimeter, 2 centimeter, 1 centimeter, 0 centimeter, like that. Length, the less is the length, better is the status, means the length of the cervix reduces from original 3 centimeter to 0 centimeter, that is fully effaced cervix. Okay. Then station of the head. Station of the head is same like previous scoring. -3 is above spine, 3 centimeter above spine, -2, -1 and 0. It is same like previous scoring. But the scoring for the points for cervical dilatation are doubled up. Instead here for cervical length and station we measure it as scoring is done as 0, 1, 2, 3. For dilatation it is given as 0, 2, 4, 6. So, like that the modified Bishop score is calculated. In both these cases the score more than favor more than 5 is good, classic Bishop score more than 8. So, consistency and position has been omitted. As such 8 instead of 5 consider it as 8 for favorable cervix. So, here it should be success depends upon the cutoff value for the Bishop score is more than 8. Need for ripening of the cervix before induction of labor is determined by the modified Bishop score. If it is more than 8, 8 or more than 8, it is okay. There is no need of ripening of the cervix. If modified Bishop score is less than 7, here it should be less than 7, then induction may be done without ripening of the cervix. Sorry, more than 7, then induction may be done without ripening of the cervix. If it is less than 7, then ripening is required. So, in short, what is the need of this Bishop score? Induction results satisfactory. What do you understand by induction of labor? Whenever patient does not go into labor, that time in post mature fetus, that time induction of labor is required after 42 weeks. That is one condition. Other cases wherever the life of the mother is in danger, or due to diseases complicating pregnancy, or there is danger to the life of the fetus. So, in these two conditions we attempt to deliver out the baby as early as possible. In these cases induction of labor is done, means normal uterine contractions are induced by the uterotonics. There are different methods of induction, those we will learn later on, but remember induction is required in these cases. If cervix is, remember in short, if cervix is more than 60% effaced, 3 centimeter dilated and station of the head is -1 station at least, then the induction results are satisfactory. It also decides the optimum time for elective induction. Suppose I am planning for induction of labor, if cervix is favorable, I can go ahead safely, and elective time is also there. Scores unrelated to expected date of deliveries gives the warning of this preterm labor or PROM or post maturity. Means cervix is not ripened, means patient is in preterm labor or may not be in labor. So, we can correlate our findings whether patient is near the expected date of delivery or not in different conditions like this: preterm labor, PROM, post maturity. This one is the effacement of the cervix and this one is the dilatation of the cervix. Okay. We are given the case scenario where they have written 50% effaced cervix, 1 centimeter dilated, head at -1 station means 2 points, 1 centimeter dilated means 0 point, and anterior place cervix 2 points, soft cervix 2 points, total score comes to 7. Modifiers are, she is a nullipara. So, 1 point is minus and she is a patient of preeclampsia. So, +1 is added. So, total score was 7, it becomes to 6. In these cases 50% effaced means at this level we are. The half of the length of the cervix is felt, it is 50% effaced. Cervix is 1 centimeter dilated means in this phase we are. So, here the cervix is not good for further dilatation, it has to go here, it should be here or here. So, that is why the total score has come to 7 and by calculation it comes to 6. So, cutoff value is 8. Naturally, she needs ripening of the cervix and induction of labor. So, in this case what is there? She is a patient of preeclampsia, mild preeclampsia, when blood pressure is hardly 140/90. So, she is already hospitalized. If the blood pressure would have been more severe, if she would have been severe preeclampsia, then we would have given her antihypertensive. She has already completed 37 weeks. We plan delivery when the lung maturity is over, that time means at completed 37 weeks of gestation. If she would have reported prior to that, there was need for giving betamethasone or dexamethasone injection. Magnesium sulfate administration is also not required in these cases, as to prevent, the magnesium sulfate is given to prevent the convulsions. It is not required in this case because she is already a mild case of preeclampsia. So, here 37 completed weeks with pregnancy induced hypertension and unfavorable cervix we are dealing with. The Bishop score is 7, it should be, it is less than 8, means unfavorable cervix. In these cases, if obstetric management I am planning for, I must decide the status of the cervix by Bishop score. So, what I have calculated? I have calculated that it is less than 8, means it is unfavorable cervix. Cervix should be ripened first, then plan for induction of labor. If cervix remains unfavorable after ripening also, attempt of ripening also, then caesarean section is performed. Otherwise, there is no need of caesarean section in this case scenario. Okay. How do you do the ripening of the cervix? You must understand the intracervical is the intracervical dinopros gel or cerviprime gel is the best gel to dilate the for ripening of the cervix. It is prostaglandin E2 gel. The dose is 0.5 milligram. You have to repeat it 6 hourly, and then after 2 6 hour doses, you have to start the pitocin drip or oxytocin drip for the patient. Start the dose of oxytocin 2 milliunit per minute. The dose is very less. You prepare the dose of 2 milliunit per minute. Increase every 30 minutes. The dose has to be increased every 30 minutes by same dose 2 milliunits per minute, and when the cervix gets dilated up to 3 centimeter, that time artificial rupture of membranes is done, so that there is descent of the head, it compresses the cervical rim and it favors normal uterine contraction with the Ferguson's reflex, and that is how the patient goes into the labor. In the labor, continuous electronic fetal monitoring is required. Keep the partogram also for the progress of the labor, where we assess every hour the descent of the head per abdominally and by PV examination, and uterine contractions every 30 minutes we assess, then the dilatation of cervix. So, these 3 points are assessed in partogram. So, we monitor the fetus, we monitor the mother whenever induction of labor is planned or ripening of the cervix is done. Postpartum hemorrhage is prevented in preeclampsia because of high blood pressure. There is chance of postpartum hemorrhage by giving intra-umbilical injection of oxytocin 10 units. Prophylactic use of methergine is avoided in preeclampsia. So, we have learned one most important thing, avoid use of methergine in preeclampsia. Monitor the blood pressure for 24 hours after delivery at least, because there is a risk of postpartum hemorrhage and convulsions also. Other methods to ripen the cervix are, you must remember, RU486, they are rare method. Somehow mesopost is also 25 microgram vaginally is also popular. Intracervical use of Foley's catheter or laminaria tent is also used, but there are more chances of infections. So, sometimes they are avoided, they are not preferred. At the end, let us remember this mnemonic Bishop. For the Bishop score, I shop. I stands for effacement, S for station, H for hard cervix or soft cervix, opening of the dilatation for O, and presenting part. What is the station? That is how the Bishop score you have to remember forever, and that is how the management also we have discussed in relation to this case scenario of preeclampsia. She was a patient of preeclamptic cervix, and we have ripened the cervix and lastly she was subjected for induction of labor. That was the plan of treatment in the given case. Thank you so much for the patient hearing. Thanks a lot.